Assalamu alaikum everyone. For those of you who don't know me, my name is Mohammed Alfuwais. I'm a fourth year medical student. First of all, Ramadan Mubarak to you all. Inshallah, Ramadan is going well, and may Allah accept all our deeds, inshallah. So inshallah, this time it will be a new session that I'll be giving. It's a crash course. I'll be going over all of GI, inshallah, with you guys in the 3 sessions I'm going to give. This first session will be the upper GI, which I'll be talking about the esophagus and the stomach. The way I'll be doing it is I'll start by the basics, just generally what is the esophagus, and then the important anatomy and physiology stuff. But then we'll go into the pathology, the clinical, micro, pharma, everything, inshallah, with radiology as well. So this will be a full encompassing thing. Anything that's important for your OSPE, I will say. Okay, I'll tell you like this image is important to know for your OSPE. So, this session, like all my sessions, has to be interactive. So I need you guys to answer my questions whenever I ask. So let's start, inshallah. So as I said, we'll start with the esophagus, and then we'll go into the stomach, and we'll cover everything in these 2 organs for today. So before I begin, this block is heavily reliant on surgery. There's a lot of surgical stuff in this block. So I put this slide as a reference for the terms that we use in surgeries, okay? So for example, ectomy is when we try to cut something out. So for example, esophagectomy, if I say that, you're removing the esophagus. Gastrectomy, you're removing stomach, okay? Cholecystectomy, you're removing the gallbladder. These are the terms. To me, it's just to cut something, okay? It's not really to cut it out. It's just to make a cut. So for example, if I say myotomy is to cut a muscle, okay? We're not cutting it out, we're just cutting it. This is, for example, if it's too constricted, we're going to cut it to allow it to become bigger. Ostomy is to make a connection or make an opening. So for example, if I say, later on, inshallah, in the next lecture, I'll explain stomas, for example, generally. If I say ileostomy, we're making a connection between the ileum outside, okay? So making an opening outside. Then the last term that I want you guys to know from this list is plasty. Plasty is just to change something, okay? Repairing something. The only term you need to know in this whole block is pyloroplasty, okay? Which is basically to change the shape of the pylorus. And we'll get to that later. But if I say ectomy, otomy, ostomy, now you guys know what that means, okay? And I'll repeat them again, inshallah. So without further ado, let's go into the esophagus now. So the esophagus is an organ, the first organ in your GI other than the oral cavity. Its function generally is to move food from your mouth all the way to the stomach, okay? And it's involved in the swallowing reflex. Now it's around 25 centimeters long. It has 3 parts: the cervical part of the esophagus, thoracic, which is the largest portion, and then here you have the intra-abdominal portion, which is the shortest portion, okay? Now, for the esophagus, something that you really, really need to know is its involvement in the swallowing function. So the swallowing phases, there's 3 phases. What's the first phase, guys? What's the first step in swallowing? There's 3. Oral, good. So the first one is oral, okay? The second one is pharyngeal. The third one is esophageal, okay? So the first phase is oral. It's when you move the food to the back of your tongue. Then it goes to the pharynx. From the pharynx, you have shutting of the soft palate, shutting of the epiglottis, and moves down to the esophagus. The longest phase from these 3 is the esophageal phase. Know this fact very well, that the longest phase in the swallowing phases is the esophageal. The oral, you can say that the oral preparation, which is right before the oral phase where you chew the food, is the longest. However, technically speaking, the esophageal phase is the longest part. It's around 8 to 20 seconds, okay? Now, the main function, other than obviously moving food, is through peristalsis, okay? So the way it does it is you have the bolus of food here. Proximal to the bolus, it contracts. Distal, it relaxes. This is important for when we go into manometries, okay? So you always have to have a sort of contraction that's going on with relaxation. Now, the lining of the esophagus is very important. The esophagus is lined by stratified squamous non-keratinizing epithelium. This is the entirety of the esophagus. If you have changes that happens, for example, in chronic GERD, and it turns into something else, that's what we call metaplasia. And we'll get to that later, inshallah. One other small fact that you need to know is the esophagus, the upper 1/3 has striated muscles, while the rest of the esophagus is only smooth muscles. Why is this important? If someone has myasthenia gravis, this can cause swallowing issues, okay? So that's pretty much it in terms of the esophagus anatomy. Now, one other important thing about the esophagus is its protective mechanisms against acid. Because the two main pathologies that you're going to need to know in the esophagus is dysphagia, difficulty swallowing, and gastric reflux, okay? Gastroesophageal reflux. So the most important protective mechanism for reflux is the lower esophageal junction. The lower esophageal sphincter is the most important one. Now, it's not a true anatomical sphincter, it's a physiological sphincter, that there's no like clear distinction that this is the sphincter, okay? It's not like the pylorus where you have the thickened muscles and so on. It's different. The other functions or the other protective mechanisms is firstly the angle that it goes to the stomach. It's at an oblique angle. This protects it. The other thing is going to be the peristalsis that the esophagus has. It can move the acid down, as well as bicarbonate that happens from the saliva. It protects the acid as well. Then you have the intra-abdominal portion of the esophagus. The intra-abdominal pressure is far greater than the thoracic, so it shuts down basically the lower esophagus. It doesn't allow food to go up, okay, or any acid. The other thing is the diaphragm. The diaphragm will sit right here. So this is the crura of the diaphragm, and it basically closes this the lower esophagus. One important part of the diaphragm around the esophagus is this, the phrenoesophageal ligament. If by any chance you have weakness of the phrenoesophageal ligament, what do you develop? What is the pathology that you develop if you have hernia? Good. What hernia specifically? We'll get to that, inshallah, in the slides next, okay? So that's pretty much the protective mechanisms. Now, if you're trying to evaluate the esophagus, there's many ways. First of all, you can do a barium swallow, which is basically you tell the patient to swallow this contrast. And then after they swallow this contrast, you do imaging like an X-ray, and you can see the esophagus. You can see if there's any filling defects, if there's any masses, if there's anything wrong with the esophagus generally. Then you can do an endoscopy, which is you put a tube and you visualize it. The third one, which is the functional study, which is manometry. Manometry will see the pressure changes throughout the esophagus while the patient is swallowing, okay? So you tell the patient swallow this and you record the pressure changes that's happening in the esophagus. So starting off with the pharynx, obviously when you first swallow, you want everything to contract to push the food down. So you're going to have elevation of the pharyngeal pressure. Upper esophageal sphincter will transiently, very fast, relax to move the bolus of food, and then it contracts right after. So that's happening next. Then it moves downwards. So next you'll have the same thing. The upper esophagus contracts and relaxes. Middle contracts, relaxes. Lower, and so on. Then you go into the lower esophageal sphincter, which will transiently relax, okay? And this is basically, if you look at the pressure of the lower esophageal sphincter, it's high. Resting pressure is high. This is to prevent any reflux from happening. It transiently relaxes to allow the food to move through. This is the normal. Two things that can happen here. Either you affect the peristalsis that's happening all throughout, okay? This will cause difficulty in swallowing, or there's something wrong with the lower esophageal sphincter. Either it's too constricted, okay, or it's too relaxed, okay? These are generally the two pathologies that can happen here. Let's take an example. Here, an example, the pharynx is normal. You can see the increase in pressure. Upper esophageal relaxes normally, then constricts normally. Upper esophagus is normal. Then you go into the middle and the lower esophageal sphincter, the pressure is low. What is this disease? Scleroderma. Tamam. Specifics of this, inshallah, a slide separate for this. Same thing here. In achalasia, you have abnormal peristalsis in the esophagus all throughout. The lower esophageal sphincter will fail to relax in achalasia. So because of this, you can see that the peristalsis is abnormal throughout the esophagus. You can see that the pressure increase is less than normal. This is the normal, and then this is the upper esophagus in achalasia. The middle and lower, obviously very, very abnormal. Then the lower esophageal sphincter, the pressure is so high, okay? So food cannot pass through. Then here in diffuse esophageal spasm, it's spasm, like the esophagus will spasm, okay? So the contractions will be very, very high. And that's what's happening here, okay? With the pressure. Now, pharyngeal paralysis, someone who has stroke, obviously what will be affected? The upper esophagus and the pharynx. Why the upper esophagus? Because there's striated muscles here, okay? So that's basically the basics of manometry. We'll go over each of these diseases in its own separate slide. Now, in the clinic, this is what we look at. This is what the actual manometry looks like. Now, the colors that you see here, there's blue, there's green, there's yellow, there's red, and there's purple, okay? The blue, green, yellow, red gradient is the pressures. So blue is very low pressure to no pressure. Green, there's an increased pressure. Yellow is even more pressure. Red or very dark red there's high pressure that's happening in the esophagus. We look into this to see the peristalsis. Is the contractions happening normally? Is the lower esophageal sphincter relaxing normally? Is the upper esophageal relaxing normally? Is there any pathologies here? And to check for hiatal hernia. Okay, this is what we're looking at when we look at this manometry. So let's look at actual example of this, which is this. This is a normal manometry. There's nothing abnormal to this. It's recording the pressure changes in the esophagus over time. So for example, if we start recording here, this is at 1 second, this is at 2 seconds, 3, 4, 5, and so on, okay? So it's recording the pressure changes over time, okay? So the first thing that has to happen is that the upper esophageal sphincter has to relax transiently to allow the food bolus to move down. Tamam? And then you can see that it contracts distally, it relaxes. Contracts distally, it relaxes. Contracts distally, relaxes, and so on until it moves here. If you look at the lower esophageal sphincter, it relaxes from the very beginning until the food bolus moves down, which is at this point over here. Tamam? This is normal. This is a normal manometry. Now, how can I say if this patient has hiatal hernia, which is another thing you need to be aware of? You look at if there's two lines. This line is normal. There's not really much in this line. However, if you have a clear double line that's separated like a lot, this is hiatal hernia. We'll get to a slide separate for this. Now, what is this purple thing over here? This is what we call impedance study. Impedance study is, we do it if we're suspecting that this patient has a motility disorder with GERD. Okay, so we're trying to see if they have reflux. What is impedance study itself? It's basically looking at the changes in charges that's happening throughout the esophagus. So in this patient over here, obviously, if we want to assess manometry, we ask them to swallow something. Okay, so they're probably drinking juice or something. So obviously the changes in charges will happen. If they're drinking something, eating something, it will happen. So it's happening along with the peristalsis. It's happening along with the esophagus actually functioning normally with the peristalsis. When would it be a sign of reflux? If this purple color is appearing over here, around here. If it appears after the peristalsis is done, after esophagus moves everything down and then it appears later, this is a sign of reflux, okay? That's the only thing you need to know about impedance. There is this slide as well, which is basically, it's not in the manometry. We do a pH impedance, same exact concept. Here, what we're looking at is this. You see these dotted lines? This is when we start recording, okay? So over here, the patient, we ask them to swallow. So they swallow. And then it moves down over time. Not a great line for me, but honestly, but it moves down like this. This means that going from up to bottom, this is the change that's happening, which is normal because they're drinking something or eating something. If we start recording from here, from down here, and we see that it's moving upwards slowly, this means that there's reflux. The significance of this is not that important, but for concept's sake, this is it, okay? The reason why we do this is to check for reflux. That's it. So there are specific terms and definitions that you guys need to know. First of all, is how do we know if the esophagus is contracting properly? We use an index or an integral called DCI, distal contractile integral, which has normal ranges. If it's between 400 to 8,000, it's normal. If it's below 400, it's ineffective, okay? If it's above 8,000, it's hypercontractile. When is this important? If someone has ineffective peristalsis, if someone has, for example, esophageal spasms, jackhammer esophagus, which we'll get to later, and so on, this is when we can use it. Okay? So if it's ineffective, we can separate them into two. Weak, which is 100 to 400, and then below 100, which is failed. Okay? So in this case, the DCI is 18, it's a failed. And then if it's between 100 and 400, it's weak. Okay? And again, if it's above 8,000, sorry, then this is a hypercontractile esophagus. Last term that we're going to do before we go into the pathologies and so on is a distal latency. The distal latency is basically we start from the relaxation of the upper esophagus, okay, upper esophageal sphincter, to this, which is the contractile deceleration point. It's when the contractions start to slow down a bit, okay, because after this, it's just going to push the food downwards. So this difference over here is important only for one thing, which is if the patient has esophageal spasm, this will be less. That's it. Okay. So yeah, there's no actual number that you need to look at, and I'm pretty sure. It's just know the definition of this. These two, just know the normal ranges and know the definition of it. Okay. Tamam. Up till now, the basics. Any question? Or is everything clear? Because now we're going to start to apply this. Good. So, now, as I said, the two pathologies, mainly the two symptoms that you're going to get from the esophagus is dysphagia and reflux. These are the two important signs and symptoms of the esophagus that you're going to get, generally speaking. Let's tackle dysphagia, and we'll get into reflux while we're going through this, okay? So dysphagia, the definition is difficulty swallowing, okay? We can divide this into two types, oropharyngeal dysphagia and pharyngeal dysphagia, oropharyngeal and esophageal dysphagia. Oropharyngeal dysphagia is you ask the patient, can you actually swallow the food? Do you feel the food being stuck in your throat? Do you have difficulty swallowing? If they say yes, this is oropharyngeal, okay? If they tell you, I can swallow, however, I feel it stuck in my chest, this is esophageal dysphagia, okay? Let's talk about oropharyngeal. Oropharyngeal is difficulty that they have in swallowing from the mouth to the pharynx, okay, to the esophagus. So if they can't swallow the food properly, then there's something wrong with muscles, okay, typically muscles. These are the most common types. So for example, if someone has stroke, has hemiplegia, signs of facial paralysis and so on, and they tell you that they can't swallow properly, this is most likely a patient who had neurogenic stroke. That's the cause of oropharyngeal dysphagia. If then another patient that tells you, a 30-year-old female who has muscle weakness, who has diplopia and ptosis in the eyes, comes to you telling you she has difficulty swallowing. What's the cause of dysphagia in this patient? You guys tell me. Myopathy, good. More specifically myasthenia gravis, okay? The reason is the upper esophagus, as I said, has striated muscles. Okay. So if there's a defect there, then it's going to cause oropharyngeal dysphagia. Okay. And the last thing is if the patient does not have any systemic signs of any other pathology, so for example, muscle weakness, stroke signs, neurodegenerative like Alzheimer's, dementia, and is complaining to you, telling you that I have difficulty swallowing, I feel chunks of food coming out of my mouth, my breath is very bad, what am I thinking of as a cause of oropharyngeal? Zenker's diverticulum. Good, perfect. Okay. From this whole thing, I want you guys to master Zenker's diverticulum and just know that neurogenic is because of stroke, and then you have myopathic causes. Okay. The specifics of it is not important. This is the most important thing. Zenker's diverticulum. طيب. That's it for oropharyngeal. Now, if it moves past their throat and then they have difficulty moving down the food at the level of the chest, if they feel it being stuck here or in the upper abdomen, then this is most likely esophageal dysphagia. The most important question you ask these patients is it to solids or is it to solids and liquids? Okay. If it's only to solids, then this is most likely a mechanical obstruction. Okay. So mechanical obstruction or anything that's causing narrowing of the lumen. So if you have the lumen, which is this, okay, and then you have, for example, a mass that's growing here. Obviously, this is the lumen. It's far less. So if you have chunks of food, it's going to get stuck because of this mass that's over here. However, can liquid move? Yes, it can. Okay, so it can move. There's enough space for liquid to move. However, large bolus of food and stuff cannot move down the esophagus. Okay, same thing for a ring, a stricture, and so on. However, if you ask a patient and he tells you it's solids and liquids, and then you further ask him, did it happen as both at the same time, or did it start as solid, then go to liquids? It just means that there's something that's growing inside. So imagine if this mass grew to this point over here. So it's allowing only this amount of space for liquids to grow. Obviously, it's going to be to both solids and liquids. Okay, so you need to ask questions, or in this scenario, it will be written like this. It started off solids and it became solids and liquids. Okay, then if it started off as with solids and liquids, okay, both of them, you're thinking of a motility disorder, such as achalasia, esophageal spasm, and scleroderma, okay, as the three most important ones. How do you tell these things apart? You ask, there's other signs and symptoms for these diseases. Okay, so don't just say, okay, just because it's mechanical, how do I know if it's a stricture? How would I know if it's a esophageal ring? How would I know if it's malignancy? There are other signs to it. Okay, but this is just to evaluate dysphagia. Okay, and we'll get to each of these separately, inshallah, in the next few slides. Okay, this is how we characterize dysphagia. Now, if you have a patient who has dysphagia, you take it, obviously, in the scenario, you'll have a history that's there, important physical examination points. So, for example, if someone has scleroderma, they might have other of the crest features, such as sclerodactyly and so on and so forth. If they have malignancy, they'll have cachexia, they're very thin, maybe a swollen lymph node over here, and so on. So you think of cancer. The way that you then will evaluate this patient with dysphagia depends on the cause. If it's oropharyngeal dysphagia, this is the answer, always. Video fluoroscopic swallowing study. You ask the patient to swallow, it's most likely a contrast, and you take images, and you see the swallowing reflex. If it's weak swallowing, if there's something that's causing obstruction and so on, then you can diagnose this patient. Most likely, it'll be a stroke patient or someone with a myopathy. If none of these exist, and then they tell you my breath stinks and I regurgitate chunks of food, Zenker's, okay, and you'll clearly see it. That's oropharyngeal. That's majority of the time. This is the study to do. Okay, esophageal dysphagia is different. Usually, the first study you do is barium. Okay, because barium will allow you to see if it's a structural or motility. Okay, it'll show you both. If it's motility, there are clear signs of motility disorders. So acalasia will have its specific sign that you see on barium. Diffuse esophageal spasm, you'll see it on barium. Okay. Esophageal cancer, you'll see it. Ring, you'll see it. Stricture, you'll see it. Okay, through barium. After that, you check, okay, if it's a structural, I want to see it more. I want to take a biopsy maybe. So you do endoscopy using esophageal gastroduodenoscopy. Okay. If it's motility, the gold standard way of diagnosing motility disorders is manometry. Okay. This is important for you guys. If someone is suspected to have an esophageal motility disorders, the gold standard is manometry. If you have a patient who's coming to you with dysphagia, with signs of anemia, who's elderly, for example, above 60, who has upper GI bleed, you need to do endoscopy. Why is that so? Because you're suspecting cancer. Okay. And important to do endoscopy for these patients. Okay. So this is the clinical approach to it. Okay. So now we go into examples of this. So you have this patient, elderly patient, worsening difficulties. So they have dysphagia and then has retrosternal chest discomfort, so on, food getting stuck in her throat, gurgling sound, and then coughs up pieces of undigested food, and then a bad taste. What investigation would you guys want to do? Perfect. Video fluoroscopy. Perfect. Good. Now, what is your differential diagnosis from this case? Before I show you the images. Zenker. Perfect. Do you have signs of stroke? No. Do you have signs of myopathy? Does she tell you that no, she has weakness in the muscle? No. Okay. So you might think of Zenker. So you do a video fluoroscopic study and you see this. What is your diagnosis? Zenker's diverticulum. Good. So this is the normal esophagus. It's supposed to go like this. Obviously, it should be straight. However, there's an outpouching, which is the diverticula here. Now, important question for me to ask you guys is, where is this diverticulum? Where is the anatomical defect of this diverticulum? Good. Killian's triangle. Okay, so remember Killian's triangle, this word, Killian's triangle. تمام? This is a very important thing. It's in the upper esophageal sphincter, okay, or right around it. You have the cricopharyngeal muscles and so on. It's basically forming the Killian's triangle. This is where the anatomical defect for the Zenker's diverticulum. To manage Zenker's diverticulum, surgery, okay? The name of the surgery is not too important for you guys. However, just for the sake of it, it's called a cricopharyngeal, because that's where the defect is, myotomy. Okay? Myotomy, as I mentioned before, is you're just making a cut. So in this case, you're either closing it or you're just cutting this part out. Okay? So that's usually how we treat this patient. But that's Zenker's. So, now, esophagitis. Esophagitis is inflammation of the esophagus. You have many causes of esophagitis. You have chemical esophagitis, pill esophagitis, reflux esophagitis, and we'll get to that later. And you have infectious in this case. Now, esophagitis can cause dysphagia and can cause odinophagia. Odinophagia is important because this is pain with swallowing. Okay, so these three can cause pain with swallowing. Now, infectious esophagitis, it usually happens in immunocompromised patients, patients who have HIV, AIDS, taking steroids, very old, elderly patients, and so on, may get these. Okay, let's take them one by one. So you have a patient who has odinophagia, you do endoscopy, and you see gray-white pseudomembranes. You take a biopsy and you see this. What does this patient have? What's the cause of the infectious esophagitis? Good, excellent, Candida, perfect. So the cause of infectious esophagitis in this case is candidiasis, okay? The gray-white pseudomembranes is a key term. You need to memorize this one, okay? And you can see the pseudohyphae. in the image. Okay. So for example, right here, I crossed it out. But anyway, you get the point. Okay. Now another patient who had a punched out ulcer. You take a biopsy and you see this. What does this patient have? Herpes simplex. Good, perfect, excellent. Okay, which is a large multinucleated cell. Okay, and that's pretty much it, yani, about it. There's like the three M's, the marginal, molding, multinucleated thing. Just memorize these three terms in a row. Usually in the question, it will give it to you as is. Okay. Then the last one, you have a patient with shallow ulcers. You take a biopsy, you see this with intracytoplasmic and intranuclear inclusions. You think of CMV. Okay. Guys, memorize this for your OSPE. Okay. You'll get one question on this, 100%. Okay. So yeah, that's it for infectious esophagitis. Then you have this patient who tells you that I have chronic reflux and heartburn. They tried a trial of proton pump inhibitors. It did not work. They tell you that I have asthma. What does this patient have? Good. So this is eosinophilic esophagitis. It's very, 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 very similar to GERD. However, it's more common in younger age groups. Children commonly get this. Um, and the key thing here is that it's not as responsive to PPIs, and they have a history of atopy. Okay, so either this is allergic dermatitis, this is asthma, and so on. Okay, and usually it happens when they eat food that they're allergic to, not allergic, but it's hypersensitive to. Okay, then they start the symptoms of dysphagia and reflux and heartburn and so on. Key thing is when you do an endoscopy, you see these rings that occur. Okay, these rings are classical for eosinophilic esophagitis. The second thing is when you take biopsy, you need to take biopsy to diagnose this patient. The most important cell that you find in eosinophilic esophagitis, it's in its name, eosinophils, okay? There is a specific number of eosinophils that you need to see. It's more than 15 per high power field. That's the magic number, okay? This will diagnose you with eosinophilic esophagitis. How do you manage patients with eosinophilic esophagitis? What's one drug that you can give them other than PPIs that you already tried? Steroids, perfect. There are resources. Most of the resources say 15. Go with what your slide say. Does your slide say 15 or 20? Which doctor said this? Okay, go with that then. Okay. So now, the probably the most asked topic in the esophagus, GERD. Okay, you'll get so many questions on this. Okay, it's the most important topic in the esophagus. So, now, GERD happens due to, remember the protective mechanisms we talked about? If it went wrong, okay? The most important part of the protective mechanisms, as I mentioned, is the lower esophageal sphincter. If the transient relaxation is too long, if it's basically, if there's any defects in peristalsis, if there's a hernia, if there's delayed gastric emptying, if the stomach accumulates food to the point that it moves back up, if there's increased intra-abdominal pressure that's causing, for example, compression to the stomach that allows food to go back up, okay? Um, Motility disorders, increased acid or impaired acid clearance, so for example, peristalsis disorders, okay? This is usually the etiologies of GERD. Now, in terms of actual risk factors, what the patient may have, I want you guys to tell me. What are the risk factors that increase intra-abdominal pressure? Give me those. Obesity, good. Give me one more. Pregnancy, good. Obesity and pregnancy are the two more important risk factors. You need to remember those two. Other risk factors, if, for example, the patient has poor lifestyle eating habits. So, for example, they eat very heavy meals, like a lot of food, and it accumulates. The stomach no longer can hold the food, so it's just going to go up. Okay, so it moves up. That's number one. Number two is certain foods can actually cause it. For example, caffeine, mints, and some other certain foods, spicy food, can increase the amount of acid production, which can move up and regurgitate upwards. If the patient, for example, drinks or eats food and then lays down immediately, because of the gravity, it will move back up. Other things such as drugs can cause it. Drugs that delay the gastric emptying, okay, can cause it. And obviously, hiatal hernia, okay, can cause GERD. Now, if you're suspecting patient with GERD, what is the most important or the gold standard diagnostic test? Gold standard, the best one to diagnose GERD. Excellent. 24-hour pH study, okay? You probably will get questioned for this from the clinical lectures. Gold standard test for diagnosing GERD is 24-hour pH study. This is the gold standard, okay? You usually do other things before it. Okay, so for example, the first thing you do is usually give them a trial of PPIs. If they improve, then that's it, it's done. If not, then you do other stuff afterwards. But usually the best one, the most specific, most sensitive is this one, 24-hour pH study. You put a catheter or you put a capsule into the lower esophagus and you just see pressure changes, pH changes over 24-hour period, okay? This is the best study to do, okay? So, yeah. Now, for hiatal hernias as a cause of GERD, you have four different types, okay? The most important type is type 1, tamam? Now, what is the defect that's causing type 1? Where is the defect? We mentioned this before. Lower esophageal sphincter, but what ligament of the diaphragm is weak? No. Phrenoesophageal. Good. That one is Zenker's. Okay. So, anyways, here you have movement, important key term. Movement of the lower esophageal sphincter or the gastroesophageal junction above the diaphragm. Okay. This whole part goes up. So this is what we call a sliding hernia. Okay. Now for sliding hernia, if you do imaging, it looks like an hourglass appearance. Okay, that's pretty much it. Usually, this one is asymptomatic and you find it incidentally. However, it can cause GERD. Okay. Now, type 2, very important thing you need to remember, it's also called rolling hernia and phrenoesophageal hernia or something. Anyways, the most important thing is that the lower or the gastroesophageal junction is not involved in the hernia. It's in its place. What's going upwards is the gastric fundus. Okay, it's going upwards. That's the most important thing. Here, it's the gastroesophageal junction plus the part of the crura of the, sorry, not the crura, the cardia of the stomach. Okay. Type 3 is a mixture of both, and type 4 is the whole stomach moves up with parts of the intestines and so on. Okay, it's very severe, and usually you need to do surgical management of type 4. Okay, now the management of hernias, hiatal hernias, typically you don't really require surgery for this. However, if you have symptoms of obstruction, of volvulus that happens, incarceration, which is basically you cut off the blood supply to that region that's herniated, if the patient tried PPIs, tried management of GERD, didn't work, then you need to remove this, okay? So that's pretty much for hernias. Now, what does this patient have? Patient with GERD, you do manometry and barium, has these findings. What does he have? Good. So yes, this is a hernia, okay? This is a hiatal hernia. Let's look at the barium. This is where the lower part of the esophagus, or now that's herniated upwards, this is where you have this diaphragm, okay? That's constricting the part of the stomach now, okay? So this is where you have constriction of the stomach. This is where you have the diaphragm. Up here, there's another constriction point, okay? This is where you have the lower esophageal sphincter, okay? So you have this finding here, which is the hernia. This is the hernia. Over here, I said, and when you look at manometries, you need to look if there's two lines or not. This clearly, you have one line here and one line here. This line above the upper line is the lower esophageal sphincter. Okay, this is where you actually have the sphincter. Peristalsis and everything is normal in this patient. However, you see a double line. This is another one. This line is formed by the diaphragm. Okay, this is where you get the second line. Okay, this image, guys, is very important for OSPE, for your MCQ. Know how to see a hiatal hernia on manometry. Clear? Okay. Now, for the same patient, you decided, okay, I'm going to take a biopsy of the lower esophagus, and this is what I see. What is the diagnosis? GERD. Okay, good. Okay, good. GERD. Uh, Now, is epithelium, the type of epithelium, is it normal or is it metaplastic? Is it the normal squamous epithelium or is it different? Normal, good. So what's happening here? There's two things that's happening. Firstly, congestion of the epithelium with, for example, a bunch of neutrophils, lymphocyte eosinophils over here, okay? And then you have elongation of the lamina propria. The thickness of the wall is also big. You have basal zone hyperplasia that's also occurring here. How do you know that this is the basal zone that's increasing in size? It's a dark nuclei, okay? That's pretty much how you can tell. So there is basal zone hyperplasia, elongation of the lamina propria, and then you have a bunch of lymphocytes and eosinophils, okay? The eosinophils is not going to be as much as it is in eosinophilic esophagitis. Tamam? This is gastroesophageal reflux disease. This image is also very important, inshallah, for your OSPE. Come on. Now, for management of GERD, what is the first thing you do for the patient? Before that, what's the first thing you do? Before lifestyle, excellent, good. So the first thing is lifestyle. Avoid triggers, exactly. So for example, if the patient is obese, lose weight, okay? That's number one. Number two is if their eating habit is wrong, they eat heavy meals, they lay down after they eat, you tell them to stop, okay? So this is the first line management for any patient with GERD. You follow up with them. It didn't work. What do you do next, guys? If it did not work and they still have GERD, what do you do? Exactly. You give them PPIs. Okay, medical management, which is usually with PPIs. Okay. They come back to you 2 months later. Okay. You try a trial of PPIs with them, didn't really work. They still complain. You give them more, still complain. Then what do you do? If nothing's working, what is endo? Okay, what are you trying to do with endoscopy? Surgery. Okay, surgical. Tamam. Now, surgical management, I just want you to know the principle of this. The whole defect injured is the lower esophageal sphincter. There's something wrong with it. It's not strong enough. So what do you try to do? You try to make it stronger. That's the whole point of surgery. So you have these surgical managements and stuff you do for GERD. The first thing, the most important surgical procedure is Nissen, fundoplication. Okay. What do they do? Just for concept, so you can visualize this, is the lower esophageal sphincter is not strong enough. So we're gonna put tissues around it to make it strong. Okay, what is a tissue? The stomach. So you pull up the fundus and you just wrap the esophagus with it. Okay, and guys, like I'm gonna be very honest. I attended a surgery where they did this. It's exactly what this looks like. Okay, they literally pulled up the stomach and just wrapped the esophagus, the lower esophagus, and done. Okay. Nissen is 360, so it's around the esophagus fully. There are other two, such as door and toupee. You don't need to know them, صراحة, so ignore these two. But door is anterior, toupee is posterior, and that's it. Okay. I don't think you need to know the specifics of them. Okay, so door is just anterior, toupee is 270 degrees posterior. Okay, that's it for this. There is another thing you do, or you could do, it's called Colles gastroplasty. For Colles, you basically cut the stomach from the top, okay, from the, what's it called, from the fundus. You take that piece and you just wrap it, okay? You're not taking the whole fundus up and then you move it. No, it's just, you take that piece that you cut, okay? That's it. The most common surgical procedure that we do is Nissen, okay? This is the most common one that is done, tamam? So that's it for surgical management. You don't really need to go into details of them too much, okay? Yes, okay, so it technically does increase intragastric pressure. However, the whole point is you're increasing the pressure of the lower esophageal sphincter. Because you're increasing that pressure, food won't be able to go up easily. Okay, that's the whole point of this procedure. Okay, good. Now, a patient who has GERD, GERD for a very long time, comes to you later on for a follow-up. You do endoscopy, you see this. What complication occurred? Barrett's esophagus, good. So Barrett's esophagus is intestinal metaplasia that occurs, okay? So from the name, metaplasia means the tissue is changing, okay? So what is it changing to? You guys tell me. Good. Simple columnar with goblet cells, okay? If you look at the endoscopy, this white or very light pink is the normal esophagus. This part over here is the gastric or the intestinal metaplasia that's occurring in the esophagus. Here again, this is the normal esophagus. This is the gastroesophageal junction. You can see later on, it turned all into the same color because it all went through metaplasia, okay? Usually in the very distal esophagus where you have the sphincter, that's because of the reflux that's occurring, okay? So what happens or what is a change? You have simple columnar with goblet cells. You can see the goblet cells here, okay? This is the columnar epithelium with the goblet cells. This line over here that I'm drawing, this part over here is the squamous epithelium. All past this is the columnar epithelium, okay? Now here it is with this patient, okay? Again, columnar metaplasia with goblet cells. This is a more clear image of the columnar cells. Now, the important thing about Barrett's is that it has an increased risk of cancer, okay? So you slowly will have dysplasia that's occurring with this patient. So dysplasia is starting to happen. You have increased NC ratio, nuclear changes, and so on and so forth. And then you have an intramucosal carcinoma that occurs later on. How do you manage patient with Barrett's? Okay, what do you do for this patient? Number one is it depends. It depends on how severe the pathology is, okay? So for example, if someone who do you diagnose using clinical investigations plus the pathology has Barrett's esophagus, you see that they only have metaplasia, okay? So you treat this patient as if they have GERD. So you give them PPIs and you follow them up, okay, for an endoscopy later on. So that's only if they have metaplasia. If they have dysplasia, this is where it differs. If they have early or low-grade dysplasia versus high-grade dysplasia. High-grade dysplasia is dangerous because they can develop into cancer. So for early, you don't want it to go too late. So you do more recurrent follow-ups. So for example, instead of every 1 year, you do every 3 to 6 months. with an endoscopy and you check. You give them PPIs, okay? If the patient has high-grade dysplasia, then you do resection, okay? The way you do resection isn't as important to remember. However, you can do endoscopic. So you put a tube and then you just resect it using radiofrequency ablation. Or if it's very high grade or it started to form a cancer, then you do esophagectomy. Okay, remove that whole portion of the esophagus. Is that clear for Barrett's? If you need me to repeat, I'll repeat. So good. So now, the same patient that we're following up, you came back to you 5 to 10 years later, and now you do a barium, and this is what you see on barium. What do you think is happening here? Mass, good. Okay. So typically with this patient, if they have long-standing GERD, later on had Barrett's esophagus, you're suspecting adenocarcinoma. If they're a smoker, drinks alcohol, later on has dysphagia, you're suspecting squamous cell carcinoma. Okay. So what do we call this? A filling defect, as you mentioned perfectly. Another important name, and this is something I want you guys to stick any, exactly, excellent. Any cancers in the GI will typically have this sign called an apple core appearance, okay? So as if you ate into the apple and all you have is just the core, okay? So that is a key sign that you see for any GI cancers, okay? It does not matter what cancer it is. Very important. The apple core sign or filling defect most likely is a cancer. Here in this patient, in this image, they actually have squamous cell with adenocarcinoma, apparently, because distal and then upper esophagus. Anyways, we don't really know. What do we need to do for this patient? Actually, you guys answer this. What do we need to do for this patient after we see this sign? Endoscopy, excellent, with biopsy. Okay, good. You need to see what the actual cancer is. So you take an endoscopy and biopsy of this patient, and you see this. What type of cancer do they have? Good. Adenocarcinoma. Perfect. Adenocarcinoma of the esophagus. Okay. So how do I know that this is adenocarcinoma? First of all, demographic. What demographic is more common to develop adenocarcinoma of the esophagus? Firstly, tell me, is it more common worldwide or more common in America and the West? Which one? West. Good. And most common in white males. Okay. America or the West and white males. This is important to remember. Now, next thing is location. Someone already mentioned this before, but it's in the distal 1/3 of the esophagus. Okay, so this is the lower esophagus, as you can see, and this is where you have the friable tumor, and this is a very big tumor here. Okay, histologically, it's adenocarcinoma. So what do you expect to see? Glands. Okay, very straightforward in terms of the histology. Obviously, there are different grades to this cancer, low grade, high grade, and so on, depending on how much it looks like the normal, for example, glands. If it looks like glands, then this is low grade. If it doesn't, then it's high grade. Okay, that's typically the idea behind it. What is the most important risk factor for this cancer? Excellent. Barrett's esophagus. Okay. Barrett's esophagus is the most important risk factor. There are other risk factors. However, this is the most important one that you need to remember. Okay, Barrett's esophagus. Are there genes involved? What genes? Good. One more. Perfect. Okay. TP53 and CDK or cyclin-dependent kinase 2A. Okay. These are the two genes that are implicated in those. All that's in the slide, memorize this, guys, please, because you might get a question that's literally which of the following is true for adenocarcinoma of the esophagus. You'll get something like it's more common in the West, and that's the answer. Okay? Literally everything about this, memorize. Okay? Another patient who, yeah, what cancer do they have? I was going to give you hints, but it's a question that I'm going to ask later on, actually. Squamous cell carcinoma. Good. Okay. So, squamous cell carcinoma, firstly, demographic. Where does it occur mostly? Worldwide? Is the most common cancer of the esophagus worldwide or in the West? Worldwide, and African Americans are Black males. Okay. And that's it for the demographics. Location, where does it develop in the esophagus? Mid esophagus or upper esophagus? Okay, mid to upper. Okay. What is the most important risk factors? There's many. But the most important, I want two. Smoking, one other one. Alcohol, good. Other risk factors, you have HPV can cause it. You can have achalasia, okay, can cause it. Some like caustic ingestion that may, like chemicals that you ingest, so on and so forth. That's not as important. Tobacco and alcohol are the most important ones, okay? What genes are involved in squamous cell? TP53, good. There's many here. Good. Perfect. Okay, that's all three. Okay. TP53, SOX2, and cyclin D1. Okay, memorize those genes. Now, in terms of histology and image, again, it's in the mid-esophagus. Number two is, what is the finding that we see on histology or histopathology? What is this? Every squamous cell carcinoma has this. Keratin pearl, that's it, okay? That's pretty much it. Now, for guys, for OSPE, memorize these two cancers, okay? You might get it as an MCQ, you pick which one is squamous cell carcinoma, you pick this, okay? Tamam. Now, someone who has dysphagia and it's only to solids has this upon further investigations. What do they have? Esophageal web. Perfect, excellent. Now, do you know what syndrome has esophageal webs? Excellent, okay? Plummer-Vinson syndrome, okay? There's a triad of three symptoms: iron deficiency anemia, dysphagia, and esophageal webs, okay? That's basically the importance of it. How can you tell the difference between this and esophageal ring is, or a stricture, is where it develops. So firstly, esophageal ring or stricture is most likely in the lower esophagus. Esophageal web is most likely in the upper esophagus. Second thing is it's not involving the whole circumference of the esophagus, okay? So it's only part of the esophagus. It's not the whole, like, area of the esophagus that's involved, okay? These are the two ways we can differentiate them. Esophageal web. Memorize what this radiology looks like. That's the most important thing, okay? Contrary, what is this? Again, dysphagia to only solids. Esophageal ring. Do you know the actual full name of it? Shatsky ring. Good. Okay, Shatsky ring. Perfect. Now, Shatsky ring could be something that develops due to chronic inflammation, okay, that occurs in the distal esophagus. So, for example, GERD. One of the complications of GERD is stricture formation, okay? Stricture or a ring that forms in the lower esophagus. Because of the chronic inflammation, you have fibrosis that occurs with chronic inflammation, and then it forms this ring, okay? Patients will have dysphagia. Now we go into the motility disorders. A patient in their 30s, 40s tells you I have dysphagia to solids and liquids. You do a barium and you see this. What is the sign called first? Bird's beak appearance. What's the diagnosis? Acalasia. Perfect, good. Now, acalasia is due to the main pathology behind it is basically where you have loss of inhibitory neurotransmitters. Where exactly? In the myenteric plexus. Obviously, the GI has its own nervous system, if you want to say, which is the myenteric plexus. This myenteric plexus, you will have inhibitory neurotransmitters that secretes nitric oxide and VIP, okay? Vasoactive inhibitory polypeptide, okay? VIP and nitric oxide. If you have loss of these, it's not going to be able to relax, okay? So the lower sphincter will be contracted, hypercontracted. So it's not going to allow food to go through. With acalasia, you have widespread peristaltic or esophageal dysmotility, okay? The whole peristalsis of the esophagus won't be functional, okay? This is very important to remember, that the peristalsis is abnormal in acalasia, okay? So you guys did good for this one. Now, same patient, you do manometry. What do they have here? Perfect, no lower esophageal sphincter relaxation. What is the diagnosis? Okay, acalasia, okay? Acalasia has three types in terms of manometry findings. There's this one, which is type 1 acalasia. How do you know this is acalasia? How do you know that this patient is actually just not swallowing? Okay, how do I know like if this is a trick or not? Look at the upper esophageal sphincter. Okay, it's relaxing, meaning that they're swallowing something. Okay, it's relaxing, and then you have the contraction. However, you can see the lower esophageal sphincter is not changing, and it's actually more pressure than normal. So this is number one. The lower esophageal sphincter is not relaxing. It's hypercontractile, if you want to say. Number two, is there normal peristalsis that's occurring after the upper esophageal sphincter? No. Okay, there's no peristalsis at all, actually. So this is how I can say that this is acalasia. There is no abnormal peristalsis. Number two is that the lower esophageal sphincter is contracted, is hypercontracted. Okay, it's not relaxing. Is this clear for type 1 acalasia? Okay, tamam. Again, the two most important things you look at is abnormal peristalsis and the lower esophageal sphincter. This patient is clearly swallowing because of the upper esophageal sphincter that's relaxing. Okay. Number two, this is what type of acalasia? Again, there's three. We just did type 1. For what do you expect this one to be? Type 2. Okay. So type 2 acalasia is slightly different, same concept. Again, you can see here, the upper esophageal sphincter is relaxing, okay? The lower esophageal sphincter is not relaxing. So does this fit acalasia? Yes. You need to look at one more thing, which is there normal peristalsis? There's no normal peristalsis. The difference between acalasia type 1, acalasia type 2 is that the esophagus, there's already pre-existing or prior pressurization, being that even before they even swallowed, the esophagus is sort of contracting, okay? But it's not normal. This is not normal. You're not supposed to get this, okay? So this is why we say this is type 2 achalation, okay? The key term here is there's prior pressurization. Even before they start swallowing, there's pressure that's occurring in the esophagus, okay? Again, abnormal peristalsis, lower esophageal sphincter is not relaxing. Tamam? Good? Yes or no? Okay. Last one is this one. This is what type? Type 1, type 2, or type 3? Type 3, good. Type 3 is what we call spastic acalasia. Okay. Again, this type 3, the criteria. Is there normal peristalsis? Is the lower esophageal relaxing? The lower esophageal sphincter is not relaxing. Immediately we think of acalasia. Then we look over here. Is there normal peristalsis? From this point over here till here, is there peristalsis that's happening? Not really. Okay. Then we look over here, it's hypercontractile. It's spastic. Okay. This fits the description of type 3 acalasia. Okay. The most important things for you guys to remember is in acalasia, either type 1, type 2, type 3, there's abnormal peristalsis, and the lower esophageal sphincter is not relaxing. That's it, okay? Type 1 is that there is absent peristalsis. Type 2 is there's prior pressurization. Type 3, there's spasticity. Okay, that's it. Tamam. Now, for acalasia, how do you manage this patient with acalasia? First of all, is what medical management can you give to this patient? What drugs can you give to this patient? And excellent, good. Calcium channel blockers. Any other drug that you can give? To answer your question, not all typically. It's mostly type 1 that will have the bird's beak appearance. The reason is because it's not, if you look at type 1 acalasia, there's absent peristalsis, which if you look at the bird's beak, the lower esophageal sphincter is closed. That's why you have the beak itself. Everything proximal to this obstruction is dilated. So there's no peristalsis. Okay. Now, the other drug you can give is nitrates, okay? So the whole purpose of this is to dilate it. Okay, if this didn't work and the patient wants surgery, there is a surgery you can do, which is called a Heller's myotomy. Okay, just ignore that. Basically, you cut the muscle that's around the sphincter to allow more space. That's it, okay? That's the whole point of it. There's a new surgery called POEM that Dr. Walid mentioned in your lecture, probably. You don't need to know the specifics of it. If the patient can go to surgery and wants other treatment, what can you do for them? If they failed medical management, if they didn't respond to calcium channel blocker of nitrates, if they can't do surgery, perfect. The first thing you do is usually balloon dilation, actually, before all of these. Balloon dilation is the treatment method. If it didn't work, then you try these other things. Thank you, actually, for reminding me. There is something you can do if they can't do surgery, which is botulinum, okay? You inject Botox. However, the efficacy is only 6 months, okay? Then you need to do it again. You can do stenting as well, but the main management is balloon dilation, okay? Didn't work, you try medical management. If this didn't work, you try surgery. If they can't do surgery, you do Botox, okay? And that's it for acalasia. This is what Dr. Walid wants you to know from his lecture, the surgical esophageal things, okay? Now I go to this. What does this patient have? Okay, I can see why, but it's not the answer I'm looking for. I can see why, though. You have a good point. Okay, so let's go over it one by one. Does the patient have normal peristalsis? Yes or no? Yes, good. The whole defect here is somewhere here, okay? This is it needs a bit more relaxation, okay, for the food to go through. So what do we call this? Outflow obstruction, okay? The gastroesophageal junction outflow obstruction. This just needs a bit more relaxation, okay? Here, there's normal peristalsis. So that's how we differentiate it from acalasia. Someone said jackhammer esophagus, which is a very good point, okay? However, typically, you need to look at one thing, which is this thing, okay? The what's it called? Firstly, the distal contractile intergrowth, which is going to be above 10,000. In this patient, I have no idea what the number is. And then the distal latency, which will be shortened because it's spastic. Okay, this is a normal distal latency. Okay, so this is EGJ outflow obstruction. Then we look into this patient. What do they have? Excellent. Scleroderma. Do they have normal peristalsis? Yes or no? No. Do they have a normal constricted lower esophageal sphincter? No. So this is scleroderma. Is their upper esophagus and pharynx normal? Yes. Why? What does scleroderma affect? Smooth muscles. Excellent. Good. Striated muscles is not affected. If the striated muscles were affected only, the smooth muscles aren't affected, what do I think of other than scleroderma? If it's only skeletal muscles that's affected. Stroke or, again, oropharyngeal. Myopathy, myasthenia. Okay, that's it. Tamam. This is scleroderma. Obviously, if you remember from MSI, you have CREST syndrome, which is limited scleroderma. Okay, so you have, for example, calcinosis, you have Raynaud's phenomena, you have esophageal dysmotility, which is what's happening here. You have sclerodactyly, and then you have telangiectasias. So typically, the patient will have these findings, okay, alongside the esophageal dysmotility and the dysphagia, okay? We do a manometry, and this is the finding that you'll see, okay? Absent peristalsis. Okay. How about this patient? Spasms, good. Good. What do we call this finding, imaging? Corkscrew esophagus, good, excellent. Okay, now the number that you need to look at here is the DCI, the distal contractile unit. The distal contractile unit will be above what number for esophageal spasm? What's a number that will say, okay, it's hypercontractile? 8,000, good. Okay, that's for esophageal spasms. Now, I mentioned here the distal latency. If you see this orange line, it's typically supposed to be somewhere here like this. However, if you see this distal latency, it's like this. You see how it's shortened? Okay. This is why I can say that this is a spasm. So that's it. In terms of, yes. Okay. In terms of what you need to know from this is know this image, corkscrew esophagus. Know it, guys. It came in 3 or 4 lectures. Okay. The radiology and the clinical, it came. Okay. They love to ask this one. And acalasia. Acalasia is probably the most high yield image from the esophagus. The bird's beak will always be questioned. Okay. And OSPE and MCQs. Okay. How about this patient? Now it's jackhammer. Good. Again, this DCI, the distal contractile integer, will usually be above 8,000. For jackhammer, it could be even above 10,000. Okay, for jackhammer esophagus. Uh, is that the only thing that this patient has, or does this patient have something else? Hernia. Excellent. Good. You see 2 lines here. One line, which is the lower esophageal sphincter. The other line is the diaphragm. Okay. So they have 2 things, jackhammer esophagus and hernia. For esophageal spasms and jackhammer, typically the patient will tell you they have dysphagia to both solids and liquids because it's a motility disorder. Other than that, they'll tell you that they have a squeezing chest pain because of the spasm. Okay, that's occurring. I've attended clinic once, and typically, like the exact description, which I just gave you, I have difficulty swallowing solids and liquids, and I feel squeezing chest pain, and immediately, and everyone thought of esophageal spasms. Okay, now last couple manometries. This patient over here. First of all, just look, isn't peristalsis normal? No, it's not normal. Okay. Um, yes, exactly. This typically, look at the DCI. If it's below 400, as I said, it's ineffective. تمام. Then you have, if it's 100 to 400, it's weak. If it's below 100, it's failed. This case, it's ineffective. Okay, it's just ineffective. It's weak. Esophageal motility. تمام. This patient over here has normal uh, peristalsis, except this. It's fragmented. تمام. This is fragmented peristalsis. How about this patient? Butterfly effect because of coiling of the endoscope. Okay, that's it. Now, a few things to remember for we're done with before that, if is there anything you guys want me to go over for manometries, or is everything clear? It is very important. You'll get probably one OSPI question and then a few MCQ for manometries. It's very, very important. Any questions, anything you want me to clarify before we move on? Yes, it's just more severe spasm. Okay. Now, someone who has esophageal tears, you have two types. Let's look at this first type. Superficial linear laceration causing hematemesis. You don't need to do surgical intervention. What type of tear does this patient have? Mallory-Weiss tears. Typically, someone who has vomiting, retching, alcohol drinking, okay, can cause Mallory-Weiss tears. Less severe than the other thing, which is deep transmural tears that usually will rupture the esophagus, causing mediastinitis. You need to do surgery, and so on. What is the second one? Boerhaave syndrome. Perfect. Memorize these terms, the key terms: linear laceration versus transmural tear. Okay, this is very important. Know these two terms. Usually, the risk factor behind them is firstly Mallory-Weiss. What's important about Mallory-Weiss is you differentiate it from another cause of upper GI bleed. What is the other cause of upper GI bleed that's very similar to Mallory-Weiss tears? I won't be covering it today. I'll be covering it, inshallah, in the liver portion. Varices, good. Which one is painful? Mallory-Weiss or esophageal varices? Painful. Mallory-Weiss tears. Not varices. Varices is typically painless bleeding. They're vomiting blood, and then they have signs of liver cirrhosis, portal hypertension, and so on. Mallory-Weiss tears will have pain, okay, because it's tearing the esophagus, okay? So that's the difference between them. As for upper GI bleeds, I didn't include anything from that lecture, Saha, because it's repetitive from the other pathology and other lectures that we're going to cover. But typically, what's the anatomical landmark that will differentiate upper versus lower GI bleeds? What's the anatomical landmark? Ligament of Treitz. okay, which is this point over here. This is a stomach, very small stomach, but anyways, this is the duodenum, and then this part over here. This is a ligament of Treitz. Anything above that we characterize as upper GI bleed. Okay, anything lower is lower GI bleed. Okay. Now the most common causes is peptic ulcer disease, which we'll get to later. But then in the esophagus, you have Manometry tear and you have varices as important causes. There are others, it's not as important. Okay. Manometry painful. When we get to varices, inshallah, when I cover the liver after Eid, we'll talk about varices. Okay. So that's it. Now you have this thing. In radiology, I remember we got a question on this, so I thought I put it. But basically, a coin. An infant typically will swallow this, and you need to see where it is because management differs if it's in the esophagus versus if it's in the stomach or somewhere, if they're presenting with choking or difficulty swallowing or whatever the cause is. If it's in the trachea, the coin won't be facing towards you. Okay. If it's in the esophagus, it will be facing towards you. Okay, that's it. You do a lateral view, and it's going to be the opposite sign. Other than that, trachea is more anterior, esophagus is more posterior. Okay? And we're done with the esophagus. You guys have any questions at all? You need me go back to the esophagus before we go to the stomach. Or is everything clear? So, the most important things is know GERD, know how to manage GERD, know the complications that occurs with GERD, which is bleeding, stricture, Barrett's esophagus is the most important. Know the manometry very well, and then know all the pathology images, okay, for your OSPE. So now, do you guys want a 5-minute break, or do you want me to go through the stomach now? Up to you guys. Continue, okay. So, inshallah, we won't take long uh, with the stomach, but again, we'll go through basics and we'll go to specific. Now, the most important thing about the stomach is you need to understand what are the parts of the stomach because this will relate to the pathologies that's occurring, okay? Now, the stomach will start over here with the cardia, where the first thing you see after the esophagus is the cardia. The upper part of the stomach, where usually you'll see gases on X-ray and so on, is the gastric fundus. This is the body, like all of this is the body. Then over here, you have the pylorus, and part of the pylorus is what we call the antrum, okay? Now, the more important parts of the anatomy that you need to remember is going to be this. Firstly, the sphincter. The function of the stomach is to store food, okay? It, stores food every few minutes, it pushes food out, okay? That's the main function of the stomach. So, if you were to remove the pylorus, this function is gone, okay? It's typically gone. That's in the concept number one. Number two, the location of parietal cells. Where are the parietal cells located, guys, in these parts of the stomach? Firstly, what do parietal cells do? What do they secrete? Acid. What's another important function? No. Intrinsic factor. Okay. These two functions. Okay. Intrinsic factor and acid secretion. The antrum will not have as much of these cells. Okay. Which is important. Why? Because of H. pylori, which is the main pathogen of the stomach. Okay. When it causes infection or it causes inflammation of the stomach and ulcers, it will typically be around here. Okay. However, if you have someone who has autoimmune antibodies that's targeting intrinsic factor or parietal cells, where will it be? It will be in the body, it will be in the fundus. Okay. So that's another concept. Number 2 is what artery will be right here? Or around this area. Left and right gastric. Typically, the left gastric is very close. So if you have something over here like an ulcer, it can damage this and cause bleeding. That's another concept of the stomach anatomy. Last thing is let's look at the duodenum. Right behind the duodenum, there's an artery. What's this artery? Posterior to the duodenum, there's an artery. No, SMA will be here. The gastroduodenal artery. Okay, why is this important? Ulcers. If it goes posterior, it will damage this artery, which is very close to the duodenum, which can cause hemorrhage, bleeding. Okay, we'll get to this when we go to the ulcers. Okay, this is typically the main important function of the stomach and the more important anatomy of the stomach. Okay, when you do imaging, just for your own orientation, this is the parts of the stomach that we already mentioned. This is a GI follow-through study or a barium, like not a barium swallow, contrast swallow study. And you can see parts of the stomach, okay? The fundus, the cardia, this is the whole body, the antrum with the pylorus, and then you have the duodenum, the first part, second part, third part, the fourth part will be here, and this is the start of the jejunum, okay? And then the loops of the small bowel. Now, the stomach, to protect itself, obviously the main function is to store food, and obviously it's part of the digestion. It secretes acid, okay, and it secretes pepsin, okay, and all these enzymes. Now, the important thing is that the stomach has protective functions. What are these protective functions? Number one is the acid itself is protective. Why? If you have organisms, bacteria, parasites, as long as as soon as it goes into the stomach, it dies because of the acid, okay, that the stomach produces. That's number one. Number two is to buffer that acid so our own gastric cells and mucosa doesn't get damaged. We have protective factors. You have bicarbonate and mucus that's being produced. You have normal blood supply. You have prostaglandins that's being secreted. And that's basically the majority of the protective factors. Specifically, prostaglandins, as I said, the epithelium, if it gets damaged, it can regenerate, mucus reductions, bicarb production, and then you have the blood flow of the stomach, okay, which allow it to wash out, basically. If anything goes wrong, it can form an ulcer. So what typically might go wrong is, for example, number one, prostaglandins. How does prostaglandin go down? You guys tell me. How does the prostaglandin will go down? Through what NSAIDs? Good. So NSAIDs will decrease it. H. pylori will cause a more alkaline environment, will secrete virulence factors that will cause damage to the mucus cells, okay? If you have someone who has, for example, increased intracranial pressure that will cause increased acid, it will increase the damage of the GI, and so on. Okay, so you have many of these impaired defenses that leads to these ulcers. The most important thing to remember is NSAIDs and H. pylori. Okay, these are the two. Then we can characterize these damages into two types, either chronic ulcers or acute ulcers. Acute ulcers is typically because of drugs, okay, that you give. Alcohol, someone who's drinking alcohol chronically and then took a bunch of NSAIDs due to something. Like, for example, they have rheumatoid arthritis, they're taking NSAIDs and painkillers regularly, they present with an ulcer. Typically, that ulcer is due to the NSAIDs, okay? Then chronic ulcers, or something we want to call it as peptic ulcer disease, that's when we have H. pylori. That's the most common cause of this, okay? So this is the normal basics. Then we look into the pathologies next. So we have this patient who's complaining of epigastric pain. They took NSAIDs or they've been taking NSAIDs for a while. They have this. What does this patient have? Acute what? Gastritis. Gastritis is different than ulcer. Gastritis is just, for example, if they have erosions, which is not as deep as ulcers, okay? Which is basically inflammation of the gastric mucosa. Here in this gross image, you have hyperemia, all these red points over here. This is hyperemic because of the inflammation that's going on. You take a biopsy, you can see neutrophils, for example, here, and congestion that's happening with the gastric mucosa. Risk factors, as I mentioned, NSAIDs, alcohol, smoking. Okay, that's the most important causes of acute gastritis. Okay. How about this patient? Let's just say they took an NSAID, they were under a lot of stress, have these black areas. Stress ulcers, good. If the patient had a severe burn, then had these ulcers, what do we call these ulcers? Do you guys know? There's two names that we can give. Either Cushing ulcers or curling ulcers. What is the one we give to severe burns? Curling ulcers. Good. How about the other one? Intracranial injury. Cushing. The reason why is because in severe burns, you're reducing the amount of blood supply that's occurring. So because of decreased blood supply, you can get ulcers. Okay. Same thing that if you remember, guys, from CVP, peripheral vascular disease, decreased blood supply, arterial ulcers. Okay, that occurs everywhere. It's the same thing. Okay. Intracranial injury, what happens is that there's increased vagal output. Okay, that occurs with intracranial injury. So, for example, if someone has increased intracranial pressure, increased vagal stimulation because of the muscarinic receptors will increase the amount of acetylcholine that goes and binds to it, increase acid production, Cushing's ulcer. Okay, so this is an acute stress ulcer. Management is you treat the underlying reason or risk factor for it. So, for example, severe burns and intracranial injury, you treat them as is. If someone has acute stress ulcer due to NSAIDs ingestion and so on, you just stop the NSAIDs. Okay, so that's typically that. Now, someone, let's just say a female, female in their 40s presents to you with signs of anemia and also epigastric pain. You do biopsy with immunofluorescence and you see this. What is this? Autoimmune gastritis. Okay, so this is chronic gastritis. This is over time. So chronic gastritis, we have two types. We have type A and type B. Type A is autoimmune, type B is H. pylori induced chronic gastritis. Okay. These two are important because A, it causes discomfort for the patient, epigastric pain, and so on. Number two is it predisposes to cancer. Okay. So for example, both autoimmune and H. pylori can cause gastric adenocarcinoma, and then H. pylori can cause another set of diseases, okay? So that's number one. Number two is what's the main, now the autoimmune antibodies, what are they targeting in this patient? What are the cells that they're targeting? Parietal cells. If it's not targeting parietal cells, it's targeting what it secretes, which is what? Intrinsic factor, which leads to what vitamin deficiency? B12, which leads to what type of anemia? Megaloblastic anemia. Good. Pernicious anemia. That's it. Okay. Typically, a patient will come to you with pernicious anemia. You check hemoglobin low, MCV high. If they have anemia, they might have neurological symptoms such as SCD, subacute combined degeneration. Affects the spinocerebellar tract, corticospinal tract, the dorsal column tract of the spinal cords. So that's that. Okay. Now, the location, where is this typically located in the stomach? What parts of the stomach? Fundus, and one more. Body. not the antrum. The antrum, there's less of these cells. The reason why it's body and fundus is because there's more of these cells. So of course, antibodies will target this, okay? Complications, we already mentioned them. Vitamin B12 deficiency, megaloblastic anemia, achlorhydria, which is basically you have decreased acid production because obviously it targets the parietal cells, and you have hypergastrinemia. Why? Where are the G cells located, guys? Just fun fact, where are the G cells located? If you guys know. Which secretes gastrin. Antrum. Good, perfect. So with achlorhydria, typically, which is low acid, you have hypergastrinemia because the gastrin, the function of it is to increase the acid production. Low acid, gastrin goes up. So it might produce tumors from that pathway, gastrinomas, okay? Another thing is risk of adenocarcinoma because of the chronic inflammation that's occurring, okay, in the gastric walls, okay? Now, the other type of chronic gastritis is H. pylori induced. So H. pylori is what type of organism? It's bacteria. Is it gram-positive or gram-negative? Negative. Is it a cocci or is it a rod? Rods, good. What's an important virulence factor? Give me biochemical virulence factor. Urease production. Why is that important? It's basically this. The stomach is very acidic. You need the urease to neutralize it. It forms an ammonium cloud, okay, around the H. pylori pathogen. This allows it to swim normally without being damaged with the acid around it. Obviously, it will have flagella, which will allow it to swim. It will have adhesins. Now, very important is which virulence factor will damage the intestinal cells. Damage the intestinal cells. Will cause holes in the intestinal cells. Do you guys know? Okay. The virulence factor, other than protease, is one more important toxin it produces. That's the one I'm looking for. Good. VAC-A. Okay, this. There are two important virulence factors that I want you guys to remember, other than urease and proteases and so on, that a lot of different bacteria have. This one will have VAC-A, which is vacuolizing toxin, which causes holes from the name. Number two is CAG-A. CAG-A will cause the inflammation, will activate the immune cells. Okay? These two are important. Okay, remember these two toxins. If I say exotoxins, toxins, I'm talking about VAC-A and CAG-A. VAC-A will destroy or damage the gastric mucosal cells. CAG-A will induce the inflammation. Okay. Now the H. pylori, does it invade the cells and the mucosa, or does it just sit on it? Colonize, yes, exactly. So it just sits on it. It doesn't really invade into it. What it does, the reason why it causes inflammation, gastritis, is it induces inflammation. However, it just sits on it. It doesn't actually invade. Later on, inshallah, in the next session after tomorrow, when we talk about dysentery, we're going to talk about how Shigella, E. coli, and all these, how it actually invades into it. Okay. This is obviously after the stomach. Okay. So that's it. That's all you need to know for H. pylori in terms of this. Now, the patient with H. pylori will have these signs, which is chronic gastritis. Now, this is the stomach here, okay? This whole thing is a stomach. This is the esophagus. This is the body and the fundus. This is the antrum. You can tell that the antrum is much smaller, okay? This is the pylorus, okay? This is why it's more of a triangular shape, which is not normal. It's supposed to be rectangular shape, okay? Number two, as you can see here in the biopsy, is that it's sitting on the mucosa, Okay, it's not really invading it. Okay. Now, another important thing that Dr. Aban will want you to know is what are these cells called? These big pink ones. Plasma cells, they are plasma cells, but there's a specific name to them. Russell bodies, perfect, good. Okay, these are Russell bodies. Signet rings are these cells. It's important with cancer by then, okay, later on. But this is chronic H. pylori gastritis, okay? This is just more of images to explain this. But basically, over time, you will have chronic gastritis, okay? You will have chronic inflammation. With H. pylori gastritis, you will have follicles that can form. So when follicles form, you can form lymphomas, okay? So what are two lymphomas that can happen in the stomach? Two types. Marginal B-cell lymphoma, malt lymphoma, excellent. And then one more. There's another lymphoma that can develop. This is the multoma is with H. pylori. There's another type of lymphoma. It's not as common. It's more rare. Diffuse B-cell lymphoma. Okay, good. Diffuse B-cell lymphoma. These are the two lymphomas that can develop in the stomach. Okay, just memorize them as is. With H. pylori, you have multoma. Okay. Now, if you're trying to diagnose a patient with H. pylori, what two tests will tell you that this patient is having acute H. pylori, acute infection? Now he's having H. pylori. UBT, urea breath test, excellent. And what's the other one? Stool antigen, perfect. Now, this table, the most important thing I want you guys to remember is the more specific and sensitive tests, these two that we usually commonly do. Obviously, the most specific is when you do endoscopy and biopsy, but we don't usually do that every single time. So it's not usually the gold standard. Usually we do UBT and stool. If we were to monitor this patient afterwards, we use the same exact thing. Stool antigen and UBT. Serology will tell you only that this patient had H. pylori. Either has it right now or has it had it before, we don't really know. Okay, that's the most important thing about this slide. Okay, so that's it. The best test to do if you have someone who presents with signs of, I should say, epigastric pain, ulcer, you're expecting PUD, you're expecting it because of H. pylori, the best test you do for an active infection is the UBT. Okay, urea breath test. That's it. Whoops. Now we go to these patients. Let's talk about this one. What do these patients have? What is this patient? Okay, peptic ulcer. This one, where is it located? It's a bit hard in this image, but okay, let me actually give you a clue. This patient has been gaining weight. Where is this ulcer located? Duodenum, good. Okay, this patient has a duodenal peptic ulcer disease. Now, for duodenal peptic ulcer disease, what's the most important risk factor? Causing 95% of peptic ulcer disease. 95%. H. pylori. H. pylori. Okay, peptic ulcer disease, 95% of it is due to H. pylori. Okay, for duodenal ulcer. For gastric, it's a less number, but still significant, 70%. Okay. Now the other causes of duodenal ulcer is gastrinoma, Zollinger-Ellison syndrome. Okay. Um, this is the other 5%, although it's very rare. So it's most likely H. pylori. Now, what is the most common complication of this ulcer? Bleeding, good. Where? Is it the posterior wall of the duodenum or the anterior wall of the duodenum? Posterior. Why? Which artery? The gastroduodenal artery. Okay. So the gastroduodenal artery is very close proximity to the posterior wall of the duodenum. That's why it causes bleeding. How about anterior ulcers? What can it cause? Perforation. Excellent. Good. Other than that, can cause obstruction because of stricture that can form because of the inflammation. But anyways, that's typically it. Now, what about the patient here? The patient here is complaining of weight loss, hasn't been eating properly, and epigastric pain. What does this patient have? Gastric ulcer. Good. The location there is very important because you kind of need to look into gastric ulcers. Like, for example, if someone presents with these signs, you can't really just treat H. pylori empirically. For gastric ulcers, you need to take biopsies. Now, for the ulcer itself, there are signs of it being malignant versus it being benign. Now, for duodenal, it's typically benign, okay? Usually, like 95% of the time, it's benign. Gastric, you kind of need to know if it's malignant or benign. You do it by looking at the structure, the shape of it. If it's larger than 1 centimeter, if it's not, if the borders are irregular, if, for example, if it's elevated borders and irregular borders, this is most likely going to be malignant, okay? Ulcers. Now, if the location, if it's in the lesser curvature of the stomach, it's typically benign and it could cause bleeding because of the left gastric artery. If it's in the greater curvature, it has more of a chance of being malignant. Okay, so you need to take biopsies. These are peptic ulcer disease. How about here? What does this patient have? Let's look at this patient. So this patient, both of them, have gastric ulcers, okay? This one is more likely to be benign because of the borders are regular. I don't know about the size, but if it's less than 1 centimeter, it's most likely to be benign. This patient has ulcer in the greater curvature, more likely to be malignant, okay? How about this patient? What happened to them? Perforation. What tells you that this is perforation? Air under the diaphragm. Perfect, good. Pneumoperitoneum. Okay, this. Always look at it the right side. Look at the right side. Why the right side? The left side could be deceiving, okay, because the stomach has air in the fundus, okay? So it might be deceiving. Always on the right side, this is what I always look at. If there's air under the diaphragm, specifically under the right one, under the right diaphragm, this is more likely to be pneumoperitoneum, okay, which is an emergency. This is perforated peptic ulcer disease, but there's other causes of pneumoperitoneum, obviously, okay? Now, these patients with ulcers will typically present with something called dyspepsia. Dyspepsia is a very general term to describe these symptoms, which is basically indigestion, okay? Someone who has indigestion, epigastric pain, fullness in the stomach, and so on. It's important to know how to evaluate these patients and when to manage them and, what to manage them with. Usually, the cause of this dyspepsia is H. pylori, but you need to know how to manage this. If the patient is above the age of 60 and is presenting with alarming features, so for example, anemia, for example, weight loss, evidence of upper GI bleed, for example, melena in the stools, melena is black tarry stools, hematemesis, which is vomiting out blood, then you need to do endoscopy. It's a must. You need to do endoscopy and you need to treat it accordingly. If you see cancer, you treat it as cancer. If you see peptic ulcer disease, you treat it as peptic ulcer disease, okay? With the PPIs and with the drugs that we're going to talk about soon. If their age is less than 60, this is most likely H. pylori. So you need to treat the test the H. pylori by using urea breath test. If it's positive, you treat it with the H. pylori eradication therapy, which we'll talk about soon. If they don't have H. pylori, you look for organic causes. There's nothing, then this is what we call functional dyspepsia. Okay. Now, functional dyspepsia, there's two types of this. There's epigastric pain and postprandial distress. Okay. The most important thing I want you to remember is for severe functional dyspepsia, whether this is epigastric pain or postprandial, use tricyclic antidepressants. That's it. That's all that's needed for you guys from this whole entire lecture, the dyspepsia lecture. Okay. Patient above 60, alarming features, you do endoscopy and you try to treat it. Below 60, most likely H. pylori. If it's not, you look at for organic causes. Is there gastritis? Is there ulcers? None of this. This is most likely functional dyspepsia. There's two types, epigastric, postprandial. If it's very severe, use TCAs. That's it. Is this clear? Good. Okay. And this is all that Dr. Qarawi wants you to know from this lecture, like in the big summary that he made. Okay. Now, okay, so for TCAs, TCAs are antidepressants. Patients with dyspepsia, firstly, if it's above the age of 60 with red alarming features, then you need to investigate it using endoscopy. Okay. Alarming features are, for example, weight loss, anemia, upper GI bleed, such as hematemesis, bleeding or vomiting blood, or melena in the stools. So yeah, these features are alarming features. You need to do endoscopy. If it's below the age of 60, without these alarming features, then it's most likely H. pylori. So you diagnose H. pylori, you test it. If it's negative, then you look at other organic features. You do endoscopy, you do whatever testing you need to do. You rule out everything else. If it's not anything organic, then it's functional dyspepsia, okay? Functional dyspepsia, it's two types, epigastric versus postprandial. If it's very severe, use tricyclic antidepressants. Below, like if it's moderate, mild, you may use other stuff. Like mild, you do lifestyle. Moderate, you can use antiemetics or something. Severe, you use TCAs. Okay? Tamam. Now, the drugs for peptic ulcer disease. Now, someone who's having peptic ulcer disease, there's multiple ways you can counter this. Number one is to neutralize the acid. Okay? So what are antacids that you guys know? Give me list. Give me two. I just need two important ones that are local. Neutralizes the acid. Aluminum hydroxide and magnesium. Okay. Now, aluminum and magnesium. There are systemic antacids, but we don't usually use them because of the side effects. Obviously, it will cause alkalosis. Okay. I mean, this makes sense. Okay. So we use local ones, such as the stuff that you can drink. Okay, so you have two, aluminum and magnesium. Aluminum hydroxide. What is the most important side effect of aluminum hydroxide? Constipation. Magnesium hydroxide, what's the most important? Diarrhea. So what do you do to counter this? You combine both of them. Okay. So you combine both of them and you give them both. Okay, it's as one drug. So this counters both mechanisms. Okay, so that's antacids in a nutshell. Okay, that's all you need to know. The most important thing Dr. Hatouf will want you to know and will test you on is this important side effect difference. Okay, aluminum causes constipation. Magnesium causes diarrhea. What do? You give them both. Okay, so that's that. Then you try to decrease the amount of acid. That's mechanism number two. What's the best way to inhibit acid production? What's the mechanism? Best drug you can give to inhibit acid production? PPIs, good. So PPIs will inhibit the proton pump, which is this one. Okay, so if you inhibit proton pumps, now the half-life of this drug, this is an important concept, is low. It's around 1 to 2 hours. However, you can give it once a day. Why? Does it reversibly inhibit it or irreversibly? It's irreversible. So it takes around 24 hours to 36 even for it to regenerate, to these cells, the proton pumps to come back. That's why this mechanism is important. Now, PPIs has many side effects. The most important ones that any clinicians always target, especially Dr. Fahad Suhaibani, is number one, it causes increased risk of infections, specifically C. diff infections, Clostridium difficile. And number two is pneumonia, okay? The reason is you're decreasing the amount of acid, which will damage these microbes when it goes into the stomach. Loss of acid, loss of this function, okay? So you can have infections. Number two is because you're decreasing the amount of acid. Acid is very important for calcium absorption. Less calcium leads to worsening osteoporosis, okay, and less vitamin D as well. So this is the most important side effects. However, there's so many side effects. It affects the heart, the kidneys, the muscles, many, many, many side effects, okay? But these are the ones that typically Dr. Fahad targets, okay? And he gave a bit about them in the, I believe the dysphagia, I know dysphagia, the H. pylori, he talked about them somewhere, but anyways, peptic ulcer disease one, okay? Now, there are other ways you can inhibit uh, acid secretion using H2 blockers, and then you have M3 blockers, okay? Give me an example of H2 blockers, guys. Histamine blockers. Famotidine, or the classic drug, is cimetidine, okay? Not as used as much, obviously, but cimetidine. Now, these antihistamines, they have side effects. Number one is drug interactions. It can cause, it interacts with the cytochrome enzyme, so it affects the drug metabolism. Other than that, I think drowsiness and so on, it can cause drowsiness and so on, okay? Now, for muscarinic, it affects the M3 receptors. And these are typically the drugs that you give to decrease the amount of acid production. Now, the other drugs that you can give is to basically coat the ulcer, okay? So you have sucralfate and bismuth. Important concept, sucralfate here, okay? Can you give it with PPIs and antacids? Yes or no? Can you give them both together? No. Why? It will decrease its effect. Why? Because sucralfate will need acid for it to be active. Okay, that's it. Now, what's an important side effect, like a very key side effect? What will the color of stool be? Black stool, okay? Bismuth is another one that will coat the ulcer, and it has antimicrobial effect against H. pylori, which we'll get to it. For bismuth, um, the more important side effect is also black stool, but also black mouth. Sucralfate will cause dry mouth. That's how you can differentiate the two, okay? These are typically the drugs that you can give for uh, peptic ulcer disease. There's other ones such as prostaglandin, misoprostol, and so on. Not too important, not gonna lie. And then somatostatin is gonna be important, inshallah, when we talk about some of the pancreas and the small intestinal tumors later. Okay, I think so. But anyways, that's it for the drugs used. And this is just a list of all of them. Ignore the anti-H. pylori drugs, but this is everything that we've already discussed. To remember, the proton pump inhibitors is just Prazole, okay? The classic drug is omeprazole. Systemic, you have sodium bicarb. We don't really use it because of the systemic side effects, such as alkalosis that can happen. There's also another thing with the heart, I believe, that can happen with systemic antacids. So we usually use non-systemic, which is megaldrate, which is basically a combination of aluminum and magnesium hydroxide. Okay, so that's basically peptic ulcer disease drugs in a nutshell. Someone with H. pylori now. This is very important. The classical treatment that we've all learned is the triple therapy. The triple therapy consists of 3 drugs: PPI, clarithromycin, and amoxicillin. If someone has amoxicillin allergy, what can you give them instead? Metronidazole, good. You do this for 14 days. Now, which of these drugs have the highest resistance rate? Clarithromycin, excellent. So typically, we give these combination, the triple therapy, in populations that have clarithromycin resistance less than 14%. Above it, you kind of avoid. So what do you give if it's above 14%? What regimen? If there's high clarithromycin resistance. Bismuth quadruple therapy, good. Which is PPI, bismuth, tetracycline, and nitromidazole or metronidazole, okay, whatever. Which is for 10 to 14 days, same thing. You do this if there's clarithromycin resistance in the population above 14%, or if this triple therapy, if it's less than 14% resistance, if it failed, you do the quadruple therapy. There are other therapies you can do. It's not as important to remember these ones. However, just the concept behind them, if this doesn't work, you do this. Then if this doesn't work, then you try this. Then if this doesn't work, then you do this. Okay? That's H. pylori drugs. Okay? Tamam. All the peptic ulcer disease, gastritis and stuff, is all clear? Okay. Now we go into cancer and polyps. What type of polyp is this? This is in the stomach. This is the most common type of polyp. Inflammatory hyperplastic. Good. This is an inflammatory hyperplastic polyp. From the name itself, it's because of something, inflammation that's happening. So it's H. pylori related polyp. Uh, so that's the hyperplastic inflammatory polyp. It's usually in the antrum located. And that's pretty much the most important thing to remember from this. And one more thing is it has its only type of polyp that has dilated foveolar epithelium. Memorize this term, okay? Foveolar epithelium is basically the normal gastric epithelium, however, it's just dilated, okay? That's it. Uh, so yeah, memorize this polyp. The next type is this one, which is what type of polyp? Fundic type polyp. Good. So fundic type polyp, to remember this, number one, it's most likely going to be in the fundus in the body. That's number one. Number two is it's associated with what syndrome? Or what disease in the GI? That's very important. Familial adenomatous polyposis. Okay, FAP. So to remember this, 3 Fs. Fundic type in the fundus, FAP. That's it. Okay, this is the fundic type polyp. Lastly, which is one of the more important types of polyps because it can cause cancer. It's like very high risk of cancer. So this one, I wouldn't say, okay, villus is, we use villus to classify gastric adenomatous polyps. Adenomatous polyps, you can say if it's villus or tubular or serrated or pedunculated and so on. Okay. The whole like name, first of all, you say is adenomatous polyp. If it's in the stomach, it's gastric. Okay. If it's in the colon, it's colonic. Now, the difference between serrated and pedunculated is the stalk. If it's sessile, it has a stalk. Pedunculated does not. Okay. The important thing about the adenomatous polyps is that it can form cancer. It has a high risk of cancer. So this is what's happening in this patient over here. This top part has high-grade dysplasia that's occurring in this polyp. It could be. Inshallah, for the session after tomorrow, we'll go into more details with this, inshallah, with the polyps. That's more important than the colon. So I'll clarify, inshallah, there. Okay. So now, these patients who had a polyp later on developed cancer. Okay. It could be external to these polyps, so it could be something else. Now, the two types of polyps, the cancers that can develop in the stomach is either diffuse or intestinal. Diffuse type is in young females, so that's number one. Number two, it's not related to H. pylori. It's not. It's related to a gene mutation, which is in what? It's written in the slide. E-cadherin, okay? So that's that. It's most likely going to be in the proximal stomach, and it rapidly spreads. Histology, we'll get to that later. Intestinal type is usually in elderly males, and it's related to environmental factors, such as main thing is H. pylori. Other types is, for example, smoking. In Asian populations, we have high amounts of smoked foods, so this has nitrosamines. This can cause intestinal type gastric cancer, and it presents as an ulcer. Okay, we'll get to that. Okay, and it's mostly in the distal stomach because, again, where does H. pylori happen? In the antrum. If it's in the antrum, you think of this one. Okay, intestinal type. So now we go into the subtypes. This patient, what type of gastric cancer? Is it intestinal or diffuse? Presents looks like an ulcer. It's more in the distal, and this patient had chronic H. pylori. Intestinal subtype. Good. It looks like gastric, like it looks like glands. Okay, that's why we can say it's intestinal. The more important one that I need you guys to remember is this one. This one is classic. It's commonly questioned. What type of gastric cancer is this? Diffuse. What do I call this sign? It looks like leathery appearance. Linitis plastica. Perfect, good. And what type of cells do I see here? Signet ring cells. Okay, good. This is the diffuse type. Now, these cancers usually have a very poor prognosis. Typically metastasizes. That's when we discover it. And it has very key features for these two types of cancers. Let's go over them one by one. Number one, this one. What do we call this sign? This one, the far one. Virchow node, which is the left supraclavicular lymph node. Okay. This one, as you mentioned before, is a Sister Mary Joseph nodule. Okay, which is when the cancer spreads to the periumbilical skin. Okay. Now, typically, gastric cancer and ovarian, when we go to endometrial, inshallah, I'll explain this. But usually it will seed the omentum. Okay. And when it seeds the omentum for gastric cancer, it can cause bilateral ovarian metastasis. What do we call this bilateral ovarian metastasis? Krokenberg tumor. Excellent. Now, this tumor can also seed the retroperitoneum and go to the rectouterine pouch or the pouch of Douglas or the rectovesical pouch in males. What do we call this sign? And then when we do DRE, we can palpate it in this pouch. Okay. Blummer shelf. Okay. So these are the key features. There's two more signs that I want you guys to know. That's not like there's no pictures for them. Okay, there's two skin findings that you can have with gastric adenocarcinoma. Number one is under the axilla, which is what, if you guys remember from derma. You can also see this in if they have insulin resistance. Acanthosis nigricans, good. The other sign is if they have, if you remember, seborrheic keratosis all over the body. This is what we call lesser trilate sign. This is also another sign of gastric adenocarcinoma. Okay, the seborrheic keratosis, the black velvety shaped lesion, if it's widespread across the entire body, this is what we call lesser trilate sign. It's a sign of gastric adenocarcinoma. Okay, this is gastric cancer. There's another tumor here, which is, yeah, can you guys guess it from the image before I go into the details? Carcinoid, good. This is a carcinoid tumor. It's not typically that you find it in the stomach, however, it can. The most important locations for the carcinoid tumor is the small intestine and the appendix, which we'll cover later, tomorrow, inshallah, after tomorrow. Okay, so the appendix and the small bowel. It's from the neuroendocrine cells. In the stomach, it comes from the enterochromaffin cells, the ECF cells, or the ECL cells, sorry. So it comes from there. These cells, the neuroendocrine cells, will secrete serotonin. However, if this tumor is only local to the stomach or to the small intestine, will it cause carcinoid syndrome? No. It has to metastasize to the liver. When it metastasizes to the liver, it will cause carcinoid syndrome. So the patient will present with diarrhea, with flushing, with right heart disease. So either the tricuspid or the pulmonary valves diseases, or tricuspid stenosis, pulmonary regurgitation, or the other way around, whatever. And bronchospasms. Okay, these are the signs of carcinoid syndrome. You check urine 5-1-HAA, and that's diagnostic. Okay, that's it for carcinoid syndrome. This patient over here, what cancer do they have? This is a very rare tumor. Good, perfect. Gastrointestinal stromal tumors, which come from what cells in the stomach? Okay, exactly, cells of Cajal. And what's the important tumor gene that's involved here? c-KIT. That's all you need to know. Okay. Now, this patient, the same patient had just has, you do imaging for them and you do, one more thing about the stromal tumor is the mucosa is normal. Here you have spindle cells. And then remember c-KIT, remember interstitial cells of Cajal. That's it. Okay, spindle cells over here. Now you do a follow-through study and you see filling defect. This is a sign of, most likely in this patient is gastrointestinal stromal tumor because that's what the slide said. But anyways, it's a filling defect, it's a large tumor, and so on. Tamam. Now, the last part of this part of the crash course is the gastric surgeries. Now, the most important things for me to explain here is the post-gastrectomy syndromes. Okay, what can happen? Now, there are 3 surgeries that I need you guys to know by heart in the whole entire block. You don't really need to know any other surgeries. Number 1 is Billroth 1. Number 2 is Billroth 2. Number 3 is Roux-en-Y. Okay. The whole point of this, all 3 surgeries, Billroth 1, Billroth 2, okay, is if someone had a tumor in the distal stomach, you want to resect it, you can do something that's minimally, damaging to the stomach. You don't want to remove the whole thing because of a small tumor in distal. So you move part of the stomach. That's Billroth 1. Billroth 2, you kind of remove way, way more. So up to here, for example. And then you do anastomosis, which we'll get to what that is. And Roux-en-Y, same thing. If the the guy had a tumor which is very big, you need to remove the whole stomach, you do a Roux-en-Y. Or bariatric surgery, which is basically someone who's very obese, failed medical management, failed lifestyle modification, you do surgery, you do it as a Roux-en-Y, okay? There's many surgeries, do not worry about them. One of the things we can do is Roux-en-Y. Let's explain this one by one. So the first one is Billroth 1. Billroth 1, you remove this distal portion of the stomach with the pylorus, okay? Then you just do gastroduodenal anastomosis. That's it. So it would look like this. So we draw the esophagus, stomach. There's going to be a stump here, and then this is going to be the duodenum. Okay? That's pretty much Billroth 1. Okay? The whole thing over here is you're moving this distal part of the stomach. Tamam, that's the Billroth 1. Billroth 2 is a bit more advanced. Okay? So you remove this whole portion of the stomach, the entire thing. You get rid of the entire thing. Then you leave this duodenum as a stump on its own. So like this. Okay? Why do you keep this? It's because you want the pancreatic secretions, the bile, all to go through. Then you take the rest of the duodenum, you go to the jejunum, and then you do something like this. So here's the stomach. We remove the whole big portion. Okay? This is the duodenal stump. We take the rest of the duodenum, then the jejunum, and then we do something that's called a jejunal gastro or gastrojejunal anastomosis. Okay? And then it's going to go here. Okay? So in this case, we have two limbs. Okay? This first limb is what we call the afferent limb. This limb over here is the efferent limb. This part over here is not actually going to be a line. It's going to be connected. So if I get an eraser, it's going to, whoops, that is not supposed to happen. So for example, it's going to be like this, this, and this. Okay, so you'll have this portion over here. Now here, this duodenum is going to take all the biliary secretions, the pancreatic secretions, and go through the afferent limb and combine with the food that's going to come from the stomach, the remaining portion of the stomach, and mix over here in the efferent limb. The efferent limb will be mixed. Okay. So now, if you think about this, number one is you're moving the function of the stomach, which is the storage. There's not going to be able to store food. So because of this, food will go rapidly into the small intestine. So when food goes rapidly into the small intestine, what complication can occur? Dumping syndrome. Good. Number two is here you have the afferent limb, alkaline secretions, which is the bile, the pancreatic secretions. It'll go through the afferent limb and go up to the stomach. The stomach should not be exposed to this. Okay? Should not. So when you have alkaline substances going into the stomach, what will this cause? Alkaline reflux, which is basically the bile will damage the stomach, the remaining portion of the stomach. That's number two. Number three is the stomach. If it has, for example, if typically when you're doing these procedures, you're moving the vagus nerve. Why? Because you don't want the remaining portion of the stomach to secrete acid. Okay? So if it's still secreting acid, it will damage this portion of the intestines. Okay? So it will cause damage to the intestines. Another thing that can happen is this. You have two limbs, right? You have the afferent limb and you have the efferent limb, right? The afferent limb, it can be damaged as it can basically tie in itself. It can be obstructed. It can have stenosis. It can have adhesions, which will basically obstruct it. When you have this acutely, what type of vomiting will the patient have? If you're blocking out the afferent, it's obstructed. Will the vomit have bile? No. Okay, so it will have non-bilous vomiting. Now, when you have this obstruction, that's happening in the afferent limb, where you have, anytime when you have obstruction, bacteria will start to grow. Why? Is because the secretions will start to accumulate here. When the bacteria start to accumulate here, it will start consuming nutrients. So you will have vitamin B12 deficiency, you'll have iron deficiency, you'll have this fat-soluble enzyme deficiency, which is vitamin D-A-K. This is what we call blind loop syndrome, okay? Because the afferent limb, it's not gonna go into the efferent and the mixed limb anymore. So this is what we call blind loop, okay? Efferent limb, if there's anything that can happen with the efferent limb, such as obstruction, what type of vomiting will they have? Bilious vomiting. And this is the entire lecture in a nutshell. We'll go over the slides, most of them now. So now, the better surgery to do is a Roux-en-Y. Now, a Roux-en-Y is a bit more complicated in terms of the surgery that's occurring, but basically it's this. First of all, you're cutting out majority, if not all of the stomach out. That's number one. Number two is that what's it called? Let's just explain it like this. So for example, you can have the part of the esophagus, and then you'll say we'll keep part of the stomach, okay, like this. Then you'll have the duodenal stump. Now the duodenal will no longer go up and curl up and will have a gastrojejunal anastomosis like in Billroth 2. What we'll do is this. We'll pull up or cut a portion of the jejunum and take this portion and connect it up here. So we'll take that portion of the jejunum and connect it up here. So we'll have a gastrojejunal anastomosis. However, if we remove the gastric portion and we only have the esophageal, we'll have esophago-jejunal anastomosis, okay? And the rest of the jejunum will go down. Tamam? Now, that's not enough. We need to connect the rest of the jejunum that we left here to the jejunum that we moved up. So you will have a Y-shaped. So this is a jejunal anastomosis. Is this surgery, are these three clear? Do you want me to repeat? I can repeat. So, GERD, I'm going to be very honest. This is what we do for GERD. If someone has, for example, obesity, okay, there are many bariatric surgeries. There's two common types. There's something called sleeve, where you just cut this whole portion. But if you think about this, the gastric emptying will be minimal, like very delayed, and reservoir will be very minimal. The storage will be minimal. So if you eat a bit of food, it will reflux. So if someone has GERD and has obesity, the thing that we opt to do, we prefer to do is this. Because the gastric emptying will not be, like, it won't be existing. It will just go straight into the small intestine. So it won't actually increase the chances of GERD. It's used in patients with GERD and with obesity. Okay. Now, dumping syndrome can happen in this one, but however, I looked it up in papers and stuff. This has decreased gastric emptying, like it's a little bit delayed. So the food that goes to the distal part of the bowel and so on will be slowed. So it won't present with dumping syndrome as much. However, it can happen. The most important thing, dumping syndrome is more associated with Billroth 2. That's the most important thing. And the bile reflux is with Billroth 2. Okay. So let's go through these slides. This is Billroth 1. We just basically cut the distal portion of the stomach and we anastomosis it with the duodenum. We didn't really leave a duodenal stump. Okay. This isn't done as much at all. Okay, in practice. Billroth 2, as I said, you're cutting a larger portion of the stomach, you're creating a duodenal stump, and then you're creating a gastrojejunal anastomosis. Anastomosis means connection of two bowels or two structures. So you're creating a gastrojejunal anastomosis. You will have two limbs, afferent limb and efferent limb. Afferent limb will have no food. It will have bile and pancreatic secretions. Efferent limb will be the mixed limb. It will have the food and the secretions. Tamam? That's it. Okay, for this for BIRATH 2. For Roux-en-Y, you will have three things that's happening: the duodenal stump, the gastrojejunal anastomosis or the gastrojejunectomy, and then the esophagojejunostomy or the esophagojejunal anastomosis. Okay, with the distal jejunojejunectomy. The terms are complicated, so if you want me to repeat or clarify, let me know, please. Is it clear so far, the surgeries? Yes, okay, good. Tamam. Know these. Billroth 2 has two limbs, afferent, efferent. Roux-en-Y has two anastomosis points: gastrojejunectomy or esophagojejunectomy. Number 2 is jejunojejunectomy. This is usually already done in, this anastomosis that's happening between these two, the gastrojejunectomy, we do it in Billroth. However, this is in Roux-en-Y, so we have a Y shape that's occurring. Okay. Tamam. We already mentioned dumping syndrome. Dumping syndrome, there's two phases. There's early and late. Early happens 30 minutes after a meal, because of the hyperosmolar food, it basically sucks out or allows all the secretions to come out from the intestines. All the shift will cause severe diarrhea that occurs immediately. Okay. Late phase happens hours after a meal, is because of the insulin that gets released because of that hyperosmolar load that you had. With insulin secretion, you have hypoglycemia, and obviously with hypoglycemia, you usually treat it with carbohydrate ingestion. This is easily preventable. Okay, you can advise the patient, eat smaller meals, eat complex carbohydrates, and this will fix the problem usually. Okay, and just water 30 minutes before you eat. Okay, this will fix the dumping. In this case, the carbohydrate ingestion is very minimal. Like, for example, a small amount of orange juice will do the trick. Okay. So it's not a lot of carbohydrates. This happens when you have a lot of simple carbohydrates. Okay. So that's pretty much it. However, as I said, this happens mostly in Billroth 2. So how can you fix it surgically? You convert it to a Roux-en-Y. The way you do this is very simple. Close this off. That's going to be closed. Connect these two together. Done. Okay, this is how you convert Billroth 2 to a Roux-en-Y. Okay, so that's pretty much it. Loop syndromes, we've already been through this. You can have a lot of things that's happening to the afferent and efferent limbs. Most important thing I want you guys to remember is this description of non-bullous emesis for acute afferent. Chronic afferent is not too important. However, it can be bullous, but the important thing about this is it's not mixed with any food. Okay? The most important distinction I want you guys to make is afferent is usually non-bullous, efferent is bullous. Okay, that's it. So that's it. You have other post-gastrectomy syndromes, we won't go over it too much. However, alkaline reflux, as I said, the afferent limb will have bile secretion. The bile is not supposed to touch the stomach. However, in Billroth 2, it will. So it will cause alkaline reflux. And it presents as postprandial epigastric pain with bilious vomiting because it's coming from the afferent limb, the bile. Marginal ulcers, if you don't do a complete vagotomy, which is removing the vagus nerve, you will have acid production. With acid production, it will cause ulcers that's happening mostly on the intestinal part of the anastomosis. So if you look at Billroth 2, if you didn't do a complete vagotomy, which is cutting the vagus nerve, acid will be produced. The acid will irritate the intestinal part of this gastrojejunectomy. Okay, that's pretty much the point of marginal ulcers. Retained antrum is not too important. Also, if post vagotomy, you can have diarrhea, gallstones, because the contractile function of the gallbladder will be limited, so you'll have gallstone formation. The duodenal stump leak is this. So this is the duodenal stump. If you don't close it properly with sutures, it can leak and cause peritoneal damage, so peritonitis. It's usually in emergency. It's the most common type or most common cause of mortality, which is these duodenal stump leak or perforation. Okay. And then nutritional and weight. Obviously, you'll lose weight because your gastric, the amount you can ingest is now very limited. So you lose weight, you'll have early satiety, you'll feel full very quickly. And then nutritional deficiencies. What nutritional deficiencies that you'll get? Number one is vitamin B12. Why? Because the parietal cells are the main important cells in the stomach, secretes intrinsic factor. Without intrinsic factor, because you removed it, they will have pernicious anemia, okay? B12 deficiency. Other than that, you'll have iron deficiency, calcium deficiency, vitamin B12 deficiency as well. So you'll have these nutritional deficiencies. To end off, we're almost done, very, very close to finishing. You have antiemetics, okay? So patient presents with vomiting due to any cause. You have many types of or causes of vomiting, okay? So number one, if someone who has chemotherapy or post-operative, you will try to target this chemoreceptor trigger zone or this. What? Okay, name me a drug that targets the serotonin receptor. Name me one drug. This is how we'll review it very quickly. Serotonin. That is okay. But usually it's ondansetron, okay? This one is metoclopramide. Yes, at high doses, you can inhibit both, okay? But the main mechanism of ondansetron, it inhibits 5-HT3A receptors. M1 is, for example, muscarinic inhibitors, and then you have NK1, which is aprepitant. I think is how to pronounce it. But anyways, it inhibits the substance P receptors in the brainstem region typically, okay? Vomiting center. Someone has morning sickness or motion sickness, you target two receptors, H1 and M muscarinic receptors. Muscarinic, the drug you can use here is spironolactone. Scopolamine, sorry. Scopolamine. Use scopolamine. And then these are the same exact drugs. Now, in terms of ondansetron and all these drugs, the main side effect of ondansetron and serotonin inhibitors are headache. This is insignificant, the QT interval prolongation. Metoclopramide, D2 receptor antagonist, can cause extrapyramidal symptoms, okay? Can cause hyperprolactinemia. Now, the difference between metoclopramide and domperidone is what? Metoclopramide can cross the blood-brain barrier. Excellent. So it can cause extrapyramidal symptoms. Domperidone cannot. However, the area postrema and the chemoreceptor trigger zone is outside of the blood-brain barrier. That's why it can cause, or domperidone can be effective, okay? Aprepitant is a neurokinin receptor, the substance P receptor antagonist. This is one that you can usually use when you have chemotherapy, induced nausea and vomiting, okay? Now, for the most important thing from this lecture is when to use which drug, okay? This is the most important thing. Motion sickness, use scopolamine, which is usually a patch that you put behind the ear. Morning sickness, use meclizine or pyridoxine, which are the antihistamines. Chemotherapy induced, usually we start with metoclopramide or ondansetron, and then you can use NK1, okay? Very important, usually asked question is anticipatory nausea and vomiting, use benzos, okay? Now, if someone has gastroenteritis, post-operative vomiting, use metoclopramide or ondansetron, okay? These are typically the antiemetics that we use. Side effect-wise, know the D2 receptor, which is extrapyramidal symptoms. I think that's the most important side effect that you need to know from this entire lecture. Okay, there's also another thing, which is the muscarinic. If someone has glaucoma, you don't typically give it, okay? That's typically the only other important side effect detail that you need to know from this lecture. Last slide of this is what is this disease? Excellent. Okay, good. This is a gastric volvulus. Okay. Volvulus is, we'll talk about this inshallah after tomorrow in more detail, but basically it's when the organ wraps around itself by its own mesentery, okay? Here it's a bit different due to other pathologies that can happen. It's not as important to know exact description of this. Just know the imaging, okay, of it. The esophagus should obviously be up here. The stomach is wrapping around itself, okay? The fear, this is the duodenum, by the way, and this is where the pylorus is. You can see that this part of the stomach, which should be the fundus, is wrapping around itself. It's not really supposed to be here. It's supposed to be here. Anyways, the feared complications of this is GI obstruction, perforation, and the colon will have other diseases or other, important things. But here you will have infarction of the stomach or tissue because it can cut the blood supply when you have a volvulus. Okay. With that, I conclude this part of the crash course. You guys have any questions? Anything you want me to clarify before we move to the, inshallah, part 2 on Tuesday? Good? Anytime. So inshallah, for the next lecture or the next session, we're going to go over the small bowel and the large bowel with some slides on the appendix, which is important, and the anorectal diseases. But most of my time will be on the small and large bowel diseases because it's very important. For example, IBD, polyps, cancer. These are very, very important diseases, and you'll get many questions all over your exam on these topics. Okay? So that's next session, inshallah. Thank you.